There are currently a number of unmet needs in follicular lymphoma in the relapse setting, the greatest being what do we do for those patients that have early relapse following standard immunochemotherapy, the 20% of patients that have early progression without large cell transformation. There's been a real shift to understanding that it's unlikely that additional chemotherapy in that setting is the beneficial approach, and we're incorporating earlier use of novel therapies in that highest risk group. There's also unmet need about whether patients that have a 7, 8, 9-year remission from the first-line therapy, what is that next best treatment in the second-line setting? Is it to use a similar immunochem-based approach, or should we be incorporating novel therapies? And so, much like the first-line setting where we need additional predictive and prognostic models, we need a similar approach and additional information to really help guide and personalize the administration of therapy in the second-line setting. So one of the most important information before selecting a second-line therapy is what the patient received in the first line. So whether a patient received rituximab alone versus a rituximab and chemotherapy, that is really the most critical first step to deciding on subsequent treatments. The next is the duration of therapy, of remission. So if a patient achieved a remission in the first-line setting to, say, immunochemotherapy that lasts 5, 10 years, perhaps going back to immunochemotherapy in the second-line setting would be in the patient's best interest. If a patient had a nice remission to rituximab alone, it would also be a very reasonable and appropriate thing to re-challenge with rituximab upon progression as well. And so knowing what they received in the first-line setting and the duration of response are really the two critical pieces prior to selecting a second-line therapy. A critical point in deciding what to do for someone in the second-line setting is assessing the response and how deep the response and how durable the response was in the first-line setting. We know from a number of trials now that early progression, typically within the first 2 years, portends an inferior outcome long-term. And so deciding if a patient has early progression, whether to treat them with a novel therapy or ideally on a clinical trial is key. I think we have less knowledge about what to do in those patients that have progressions not quite 2 years, but not quite 7 years in that between area, where there's a lot of gray data on whether we should be re-challenging them with a different chemotherapy. So if you had bendamustine, switching to, say, a CHOP-based therapy, or whether we should be incorporating novel therapies in that patient population.